Usually when we talk about a medical diagnosis, there's this expectation of precision, like it feels kind of like engineering.
Right, yeah, it's supposed to be straightforward.
Exactly. You break your arm, take an X-ray, you see that jagged white line, and the doctor just points at the screen and says, well, there it is. There is the source of your misery.
It's totally binary. And I mean, there is an undeniable comfort in that. We crave a visible, tangible target when we are hurting.
We really do.
We want medicine to just be categorized into structural problems that have structural fixes.
But then you step into the world of chronic pelvic pain. Specifically today, we are dealing with a condition like adenomyosis. And suddenly, that reassuring X-ray machine is just useless.
Completely useless.
We are navigating this diagnostic landscape that is incredibly murky. So I want you to imagine this scenario. You are undergoing a major life-altering surgery to remove a diseased organ. Let's say you have a uterus that is severely compromised, just riddled with adenomyosis.
Right, a really severe case.
Yeah. You go into the operating room, you undergo general anesthesia, and you are expecting to finally, maybe after years of suffering, wake up and enter this pain-free chapter of your life.
Which is the whole point of the surgery.
Exactly. But then months later, long after those surgical incisions have completely healed, the agonizing pelvic pain is still there.
And often it feels worse.
Right. It actually seems worse, spreading to your bowel, your bladder, maybe radiating down your legs. And you're left asking this terrifying question, the organ is gone. Why am I still in absolute agony?
That scenario is, honestly, it's a waking nightmare for a patient. And historically, it has also been an incredibly frustrating puzzle for the medical community.
Because it breaks all the rules.
Exactly. It entirely defies that simple binary logic we just mentioned. That logic where structural damage always equals pain, and therefore removing the damaged structure must remove the pain. When that doesn't happen, well, the entire paradigm just collapses.
And redefining that paradigm is the core mission of today's deep dive. We are going to fundamentally change how you understand the very concept of pain.
It's a huge shift.
It is. We have pulled together a massive stack of medical literature for this one. We are looking at clinical guidelines from the International Association for the Study of Pain, perspectives from leading neuroresearchers, and expert clinical analysis from specialists who deal directly with this.
And the goal is to illuminate the hidden driver of chronic adenomyosis pain, which is, at its core, a hyperreactive nervous system.
Okay, let's unpack this with an analogy because I think it helps. Think of it like a state-of-the-art home security system.
Yeah, okay, I like this.
The adenomyosis itself is the burglar. It breaks in, it causes localized havoc. But even after you catch the burglar and even after you forcibly kick them out of the house and bolt the door, the alarm system itself is fundamentally broken.
Right, the hardware is glitching.
Exactly. It keeps blaring at deafening, unbearable volumes every single time a leaf blows past the window or a shadow moves across the lawn. So today, we are looking at the alarm system itself.
That alarm analogy perfectly captures the shift in modern medical thinking. Because for a century, medicine was entirely fixated on hunting the burglar.
Find the bad guy, take him out.
Right. The operating assumption was always find the offending pathogen or the tumor or the inflamed tissue, remove it, and just assume the house returns to peace.
But it doesn't always work that way.
No, it doesn't. And understanding why that alarm keeps ringing requires us to trace how modern medicine has had to completely rewrite the rule book on how pain is biologically categorized. I mean, we are talking about a seismic shift in neurobiology here.
A shift that feels, frankly, long overdue, especially when you look at the historical evolution of how chronic pain, particularly in women, has been understood.
The history's rough.
It's grim, right, and very dismissive. We went from early 20th century ideas of fibrositis, where doctors basically just guessed there must be some invisible inflammation hiding in the fibrous tissues to explain the widespread pain patients were reporting.
Yeah, they were just grasping at straws.
Totally. And then that evolved into the concept of fibromyalgia. And for decades, fibromyalgia was deeply misunderstood, usually treated as a psychiatric failing rather than an actual physical ailment.
The stigma was immense. I mean, the prevailing medical dogma was that if a physician couldn't physically see the tissue damage under a microscope or on a scan, the pain was either fabricated or it was a somatic manifestation of psychological distress.
Which is incredibly insulting to a patient in real pain.
Absolutely. The turning point really arrived with the groundbreaking work of researchers in the emerging field of psychoneuroimmunology in the late 20th century.
That's a mouthful, psychoneuroimmunology.
It is, yeah. But essentially, they began to look beyond the peripheral tissues, the muscles, and organs, and they focused intensely on the central nervous system, the brain and the spinal cord.
And what did they find?
Their experiments demonstrated that the central nervous system doesn't just passively receive pain signals, it actively modulates them. They proved that the brain and spinal cord can drive profound pain and sickness behaviors entirely in the absence of ongoing peripheral pathology.
Wow. So the brain and spinal cord can essentially generate the experience of physical trauma without a physical injury actually happening in that moment.
Precisely. Which brings us to the 3 pillars of pain. This is the foundational framework we really need to establish before we can understand adenomyosis.
Okay, let's break that down. Most of us, I think, only intuitively understand the first pillar, which the literature calls nociceptive pain.
Right, the classic type of pain.
Yeah, it's the pain of the physical world. It arises from actual or threatened damage to non-neural tissue. So you touch a blistering hot stove, or you sprain your ankle on a run, or in the case of our focus today, you have the physically bleeding, inflamed, swollen lesions of adenomyosis stretching the muscular tissue of the uterus.
That stretching and bleeding is the key trigger.
Right. And your nociceptors, which are the sensory receptors embedded in your tissues, they fire off an electrical signal that races up your spinal cord to your brain screaming, "Hey, tissue damage is happening right now. We are under attack. Pay attention and pull away."
That is the perfect description of a highly functioning evolutionary survival mechanism. Nociceptive pain is protective. It keeps you alive.
Okay, so that's pillar 1.
Then the second pillar shifts the focus slightly, moving from tissue damage to actual nerve damage. This is neuropathic pain. It's caused by a physical lesion or a disease of the somatosensory nervous system itself.
Okay, so instead of a hammer hitting your thumb, it's a structural problem with the wiring itself. Like a severely pinched nerve in your lower back, causing that sharp, shooting sciatica down your leg. Or diabetic neuropathy, where chronically high blood sugar physically degrades the myelin sheath and the nerve fibers in the feet.
Right, the structure is damaged, but in this case, the structure happens to be a nerve. That distinction is crucial. Both nociceptive and neuropathic pain have a clear, identifiable structural culprit.
You can point to the broken thing.
Yes. But the massive paradigm shift occurred recently when the International Association for the Study of Pain officially adopted a third descriptor.
And this is the absolute game changer for anyone suffering from chronic, unexplained pelvic conditions.
It really is. It is called nociplastic pain.
Nociplastic.
Nociplastic. It is defined as pain that arises from altered nociception, meaning a fundamental alteration in how the nervous system processes pain signals, despite absolutely no clear evidence of actual tissue damage and no evidence of a disease or lesion in the nervous system itself.
Wait, hold on. If you sit across from a patient who is doubled over in excruciating agony, and you tell them there's no actual tissue damage actively causing the pain, and there's no visible lesion on their nerve, aren't you risking falling right back into that historical trap?
That is the big fear, yes.
Because it sounds perilously close to telling a patient, your pain isn't real, it's a manifestation of your anxiety, it's all in your head.
And that is the most common and valid fear patients have when they first hear this terminology, entirely because of that history of medical gaslighting we talked about.
Right, it triggers all those red flags.
But the distinction here is what makes the science so profoundly empowering. Nociplastic pain is not a psychological invention. It is not in your head in the colloquial sense of imagination or hysteria.
So what is it physically?
It is a physical, measurable, neurobiological alteration of the brain and the spinal cord's actual hardware. To go back to your analogy, the physical alarm system itself is broken.
Oh, I see. It's a hardware malfunction, not some software glitch in the patient's psychology.
Precisely. To go back to the formal definition, the human pain processing system is designed to be adaptive. In the short term, acute pain is a homeostatic mechanism. It forces you to stop walking on a fractured femur so the bone can heal.
Which is good. We want that.
We need that. But in nociplastic pain, this intricate system of nerves, neurotransmitters, and brain networks becomes maladaptive. It loses its protective value entirely. The central nervous system becomes hypersensitized.
So it's basically overreacting.
Massively. It starts amplifying normal, everyday sensory signals into agonizing, debilitating pain.
Okay, so if we take this framework and apply it to adenomyosis, we have to bridge a pretty big gap here because adenomyosis is extremely localized.
Right. It's confined to the uterus.
Yeah, it's an issue where the endometrial tissue, which is supposed to line the inside of the uterus, improperly grows into the muscular wall of the uterus itself. So you have this very specific isolated organ dysfunction. How on earth does a localized problem in the pelvis trigger a massive system-wide failure of the body's entire alarm system?
The clinical explanations from specialists really map this out perfectly alongside the broader neuro research. We have to examine the peripheral trigger first.
The actual adenomyosis.
Right, because the endometrial tissue is trapped inside the muscular wall of the uterus, it still responds to the hormonal fluctuations of the menstrual cycle. It thickens, it breaks down, and it bleeds, but the blood has nowhere to escape.
Ouch. So it creates this constant, severe, cyclical source of local inflammation.
Exactly. The tissue is essentially trapped, swelling, and releasing inflammatory cytokines and prostaglandins every single month, month after month, year after year.
So it's not just a one-time injury.
No, it's
Oh.
chronic. And this localized inflamed area is constantly bombarding the central nervous system with an unrelenting barrage of nociceptive input. Millions of danger signals travel from the pelvic nerves up the spinal cord and straight into the brain.
And the brain is just receiving these signals on a continuous loop. Danger in the pelvis, damage occurring, danger in the pelvis. It just never stops.
And the central nervous system simply cannot sustain that level of input without adapting. Eventually, the structural biology of the spinal cord and the brain begins to change in response to this constant bombardment.
It physically changes.
Yes, this mechanism is known in the literature as central sensitization. The continuous influx of pain signals literally causes an amplification of neural signaling within the central nervous system.
Wow.
The threshold for what constitutes a danger signal gets drastically lowered, and the volume knob on the pain signal gets cranked to absolute maximum.
It's the physiological equivalent of placing a microphone too close to a speaker.
Oh, that's a great way to put it.
Right. The adenomyosis is the initial sound, the voice speaking into the mic. But the nervous system creates this vicious, escalating feedback loop.
Yes, the feedback loop is the real issue.
So soon, even a tiny, barely audible whisper of a sensation gets caught in the loop and becomes a system-wide deafening screech. And because the screech is so loud, it starts affecting everything in the vicinity, fundamentally altering how the patient experiences the most basic bodily functions.
And the literature points to two very specific clinical manifestations of this feedback loop: allodynia and hyperalgesia.
Those two terms are vital for a patient trying to articulate why their body feels so entirely foreign and honestly hostile to them.
Let's define them. Hyperalgesia occurs when a mildly painful stimulus is experienced as excruciatingly painful.
Like an exaggerated response.
Exactly. For a healthy person, bumping their hip on a kitchen counter results in a dull ache that fades in a few minutes. For a patient with a sensitized central nervous system, that same bump feels like they've been struck with a sledgehammer, and the burning pain might radiate for hours.
The nervous system basically takes a level 2 input and outputs a level 10 pain response.
The volume is artificially amplified, but allodynia is even more confusing for patients.
Yeah, this one is wild. It's when a completely normal, non-painful stimulus, something that fundamentally should not hurt at all, is suddenly interpreted by the brain as a massive threat and results in severe pain.
The classic clinical example of allodynia is feeling physical pain from the light brush of a bedsheet against the skin, or extreme discomfort from wearing a moderately snug waistband.
Things that you wouldn't even notice normally.
Right. But internally, for the pelvic pain patient, allodynia is devastating. Normal bodily functions just become agonizing. The simple act of the bladder filling with urine, which should just feel like mild pressure, is interpreted as burning agony.
Or the passage of stool through the bowel is felt as a tearing sensation.
Exactly.
Yeah.
The pelvic organs are just doing their daily, mundane physiological jobs, but the sensitized brain is screaming that the body is under critical attack.
And the anatomical layout of the pelvis essentially turns this into a perfect storm, because the bowel, the bladder, the uterus, the ovaries, the complex web of pelvic floor muscles, they are all packed so tightly into the same neighborhood.
They are right on top of each other.
And more importantly, they share the same nervous system highways traveling up to the spinal cord, which leads to this phenomenon of cross-sensitization. The signals from the inflamed uterus share pathways with the signals from the healthy bladder.
The anatomical wiring basically gets crossed.
Right.
When the dorsal horn of the spinal cord, which is the gateway to the brain, becomes amplified and hyperexcitable because of the constant screaming of the adenomyosis, it doesn't neatly isolate that sensitivity to just the uterine nerve pathways.
It leaks out.
The information spills over. The alarm starts ringing for the house next door and the house down the street.
Which completely demystifies a massive frustration for these patients, because someone with adenomyosis almost never just has uterine pain.
Very rarely.
They end up burdened with what the medical literature labels overlapping chronic pain conditions. They go to a gastroenterologist and get diagnosed with irritable bowel syndrome.
Then they see a urologist and are told they have interstitial cystitis or painful bladder syndrome.
Right. They might develop chronic migraines or systemic chronic fatigue. And it's not that their bladder suddenly developed a mysterious disease or their intestines structurally failed. It's that the alarm system governing the entire pelvic floor, and eventually the whole body, is broken.
The tragic reality of modern siloed medicine is that patients bounce from specialist to specialist, collecting separate, distinct diagnoses for their uterus, their bowel, and their bladder. And they receive localized treatments for each that rarely work.
Because they're treating the wrong thing.
Exactly. But viewing this through the lens of central sensitization and nociplastic pain reveals the truth. It is one single underlying neurobiological dysfunction manifesting across multiple organs. The common denominator is the hyperreactive central nervous system.
Okay, so we've laid out the theory that the hardware is broken, but let's dive into the tangible proof of that, because this isn't just a clinical metaphor.
No, we can actually see it.
Yeah, if we put a patient with severe chronic adenomyosis pain into a neuroimaging scanner, we can physically see the hardware malfunction. The functional MRI data shows us that nociplastic pain fundamentally rewires how different regions of the brain communicate.
It's fascinating. We are talking about the alteration of canonical brain networks, specifically the default mode network, the salience network, and the sensoromotor network.
Let's unpack what these actually do, because this is where the science gets really cool. In a healthy brain, the default mode network, or the DMN, is your inward-looking system.
This is your baseline state.
Right. It fires up when you are awake, but not engaged in a specific external task. It's the network running in the background when you're daydreaming or processing autobiographical memories, envisioning your future plans, or just thinking about your sense of self.
Okay, and then you have the salience network. Think of it as the brain's executive switchboard operator, or really a highly trained bouncer.
I like the bouncer analogy.
Its sole job is to constantly scan the environment and the body, deciding what sensory, emotional, or cognitive information is the most important right now. If a loud fire alarm goes off, the salience network instantly drops whatever else you were doing and focuses all your cognitive resources on that blaring sound.
And finally, the sensoromotor network handles the physical reality of the body. It processes raw sensory input, so temperature, touch, physical pain, and it initiates the physical motor responses to those inputs.
Now, in a healthy person, these networks are beautifully orchestrated and they are often anti-correlated, which means they take turns.
They don't all shout at once.
Right.
Yeah.
If your salience network and sensorimotor network are highly active because you are deeply focused on a physical task like navigating a difficult hiking trail or chopping vegetables with a sharp knife, your default mode network, that daydreaming center, naturally powers down so you don't get distracted and injure yourself.
The orchestration is normally elegant, but the fMRI data of a patient suffering from nociplastic pain, driven by years of adenomyosis, reveals a catastrophic loss of that orchestration.
It really is a collapse of the system.
In these chronic pain states, the functional imaging shows that these networks become abnormally connected. The term often used in the literature is enmeshed.
Enmeshed, yes.
Instead of operating distinctly and taking turns, the default mode network, the salience network, and the sensoromotor network begin to fire simultaneously. The boundaries between self-referential thought, threat detection, and physical sensation just blur together.
So the network responsible for your sense of self becomes physically fused with the network responsible for paying attention to physical threats.
That sounds exhausting. What does that actually mean for the patient's day-to-day existence? What is their moment-to-moment reality like?
It creates a state of inescapable hypervigilance. The patient's brain becomes obsessively, involuntarily hyper-focused on sensory input from the body, and they physically cannot turn it off.
Because the Who Am I network is fused with the Pay Attention to Pain network.
Exactly. Their conscious reality is constantly monitoring the pelvis for danger. They lose the neurological ability to ignore their physical body. Imagine trying to read a complex book or have a meaningful conversation with a loved one while a fire alarm is flashing and blaring in the exact same room.
You couldn't do it.
You couldn't. The brain is forcefully yanking their attention back to the threat. It is cognitively and emotionally exhausting.
And it's not just a matter of the wires crossing. The actual chemical environment inside the brain undergoes this profound shift. The neurotransmitter bath that these brain networks sit in becomes highly toxic.
The neurochemistry is incredibly validating for patients to understand, honestly. We see measurable, profound shifts in the brain's neurochemical balance.
Tell me about the glutamate.
Well, patients with established nociplastic pain demonstrate highly increased levels of excitatory neurotransmitters, specifically glutamate and glutamine, in key pain processing regions like the insula. Glutamate basically acts as the main gas pedal for the nervous system.
It speeds things up.
Yes, it accelerates and amplifies electrical signals between neurons.
So the gas pedal is permanently jammed to the floor, and while that's happening, the brakes are failing. The brain relies on inhibitory neurotransmitters, primarily GABA, to calm the nervous system down and act as a brake pedal. But the literature shows that in nociplastic pain, GABA levels are significantly decreased.
The balance is entirely skewed toward excitation.
And it gets even deeper than that because the brain possesses its own built-in pharmacy, the descending pain modulatory system.
This is a crucial system.
In a healthy system, when a pain signal travels up the spinal cord, the brain can assess it and say, okay, message received, we don't need to feel this so intensely. And it sends signals back down the spinal cord to block the incoming pain signals.
It utilizes neurotransmitters like noradrenaline and serotonin to dull the pain right at the level of the spinal cord.
But in these patients, cerebrospinal fluid studies show decreased levels of these crucial descending modulators. The brain's natural ability to deploy painkillers is fundamentally broken.
The central nervous system is bathed in excitatory chemicals, starved of inhibitory chemicals, and completely lacking its natural descending pain control.
It's a triple threat.
And this specific neurobiological environment explains a symptom that almost universally perplexes patients and dismissive doctors alike: generalized sensory hypersensitivity.
Oh, right.
Because the central nervous system is locked in this hyper-amplified state, it doesn't neatly restrict that amplification to just pelvic pain signals. It amplifies all sensory input.
The clinical literature is full of these accounts. Patients with severe chronic pelvic pain often develop severe sensitivities to their environment. They become photophobic, unable to handle bright fluorescent lights in grocery stores because it triggers a migraine.
Or they become highly sensitive to loud noises.
Yeah, or even strong odors like cleaning supplies or perfumes which suddenly cause intense nausea or dizziness. And for decades, a dismissive medical establishment viewed these cascading symptoms as proof that the patient was simply anxious, dramatic, or, somatizing their stress.
But the fMRI completely vindicates them. When researchers take a patient with nociplastic pain and expose them to a moderately loud sound or a bright flashing light while in the scanner, the pain processing centers of their brain illuminate in a way that a healthy control subject's brain simply does not.
It physically reacts differently.
Yes. The patient's central nervous system is interpreting light and sound as physical threats. Their subjective reality is genuinely, physically louder, brighter, and more painful than the reality of the person standing right next to them.
This neurobiological reality is fascinating, but it sets up a truly terrifying dilemma for the patient regarding treatment. So let's return to our opening scenario. The patient with adenomyosis is sitting in the surgeon's office. They have the hyper-connected brain networks, the glutamate dominance, the whole systemic cascade, and they look at the surgeon and say, cut it out, perform a hysterectomy, remove the diseased uterus.
The logical next step in their mind.
Will removing the offending organ actually cure their pain?
This represents the most critical, high-stakes question in chronic pain management today. And the answer is agonizingly complex. It entirely depends on whether the patient's nociplastic pain is operating as a bottom-up process or if it is transitioned to a top-down process.
Okay, let's break down that distinction, starting with the scenario every patient hopes for. Bottom-up nociplastic pain. In this state, the central nervous system is highly sensitized, the brain networks are enmeshed, the chemical bath is excitatory, and the alarm is blaring. But T, that systemic sensitization is still fundamentally reliant on the continuous agonizing trigger in the pelvis.
The adenomyosis is still acting as the primary fuel source.
Right, actively driving the central sensitization from the bottom up.
In that specific subtype, the surgical intervention makes profound sense. If an expert surgeon performs a meticulous hysterectomy and entirely removes the adenomyosis, you sever the fuel line.
You stop the signals.
You stop the unrelenting bombardment of nociceptive input traveling up the spinal cord. And without that constant peripheral driver forcing the central nervous system to remain on high alert, the nervous system eventually begins to downregulate.
It slowly calms down.
Exactly. The neurotransmitters begin to balance, and the widespread pain, the hyperalgesia, the burning bladder, it all progressively resolves.
There is a landmark observational study in the literature focusing on osteoarthritis that beautifully illustrates this mechanism. Researchers identified a cohort of patients who had severe localized osteoarthritis in a major joint, like their hip or knee. But these patients had suffered for so long that they had also developed widespread centralized nociplastic pain across their entire bodies.
Classic fibromyalgia symptoms alongside their joint pain.
Right. So the researchers performed joint replacement surgery. They completely excised the peripheral trigger. And the remarkable finding was that in roughly two-thirds of those patients, after the joint healed, not only did their hip or knee pain vanish, but their widespread centralized nociplastic pain completely disappeared as well.
Because the central nervous system successfully reset itself the moment the peripheral driver was eliminated.
That is the best case clinical outcome. It proves that the central sensitization was entirely bottom-up. But we have to confront the terrifying alternative, which is what happens to the other third of patients.
This is top-down nociplastic pain. In this state, the central nervous system has been bombarded by the pelvic pain for so long, or perhaps the patient possessed certain underlying vulnerabilities, that the neurobiological alterations become self-sustaining.
They don't need the trigger anymore.
No. The canonical brain networks are so deeply enmeshed, the epigenetic changes to the neurotransmitter receptors are so entrenched that the central nervous system has learned to generate pain entirely on its own. It no longer requires the peripheral trigger in the pelvis to feel agony.
The alarm is blaring, and it genuinely does not matter if the burglar is still in the house, if they have fled to another country, or if they are dead. The alarm system has developed its own internal battery and is running the program independently.
That's a chilling way to put it, but it's accurate. The augmented pain processing is completely decoupled from the tissue damage. If a patient has transitioned into entrenched top-down nociplastic pain, performing a major surgery like a hysterectomy is practically futile for pain relief.
They go through all that for nothing.
They will undergo the profound trauma of general anesthesia, the physical insult of organ removal, the inherent surgical risks, and a grueling recovery, only to wake up 6 months later with the exact same centralized, widespread pain they had before the operation.
Which is exactly what happened to that one-third of osteoarthritis patients. They got a brand new knee or hip, but got absolutely zero relief from their widespread nociplastic pain. The joint felt better mechanically, but the central fire just continued to burn.
Yes.
If I am a patient listening to this, I am terrified. It feels like an impossible gamble. How on earth can a patient or even a highly specialized, brilliant surgeon possibly determine if the adenomyosis pain is still bottom-up or if it has crossed the Rubicon into top-down nociplastic pain before they sign those surgical consent forms?
It is arguably the hardest diagnostic challenge in clinical practice right now. We do not currently possess a simple, definitive blood test or a quick fMRI protocol that a gynecologist can just run in their office to conclusively label a patient as bottom-up or top-down.
There's no binary switch.
No, the transition is a spectrum. Therefore, clinicians must act as detectives. They have to comprehensively analyze a matrix of risk factors, dive deep into the patient's biological and emotional history, and look for subtle clinical clues to make an educated hypothesis about the fundamental vulnerability of that individual's nervous system.
So what are those clues? Why does the patient in room A develop permanent entrenched sensitization, while the patient in room B can suffer from adenomyosis for 10 years and heal perfectly after a hysterectomy?
We have to look at the risk factor.
Right. And the most glaring demographic risk factor in the epidemiological literature is female sex preponderance. Nociplastic conditions, whether it's fibromyalgia, irritable bowel syndrome, interstitial cystitis, or chronic pelvic pain, are remarkably skewed. They are roughly 1.5 to 2 times more common in biological females than in males.
And that divergence specifically begins after puberty.
The timing of puberty is the crucial clue, right? This disparity isn't simply because conditions like adenomyosis and endometriosis only anatomically affect females. It goes much deeper, down to the molecular level of how sex hormones interact with the nervous system.
Exactly. Gonadal hormones fundamentally modulate nociception and central sensitization. Estrogen, in particular, plays a fascinating dualistic role.
How so?
Well, at consistently high, stable levels, such as during pregnancy, estrogen is strongly anti-nociceptive. It acts as an endogenous painkiller, dampening the nervous system's reactivity.
Okay, so high estrogen is protective.
Usually, yes. However, at low levels, or during periods of rapid fluctuation, estrogen acts as a pro-nociceptive agent. It enhances the nervous system's vulnerability to pain, making receptors more excitable.
And the defining characteristic of the menstrual cycle is rapid, profound hormonal fluctuation. So the exact same monthly cycle that is physically inflaming the adenomyosis lesions in the uterus is simultaneously bathing the nervous system in fluctuating hormones that chemically prime the brain and spinal cord to be highly vulnerable to those pain signals.
It is a biological double bind. Conversely, testosterone generally acts as a protective anti-nociceptive hormone. It helps buffer the nervous system against developing the widespread sensitization seen in nociplastic pain.
So males have a natural buffer.
Yes. Therefore, the inherent hormonal milieu of the female body, characterized by cyclical estrogen and progesterone shifts, creates a significantly higher baseline risk for developing central sensitization when a painful trigger is introduced.
That structural biological explanation makes perfect sense. But the clinical literature also forces doctors to look deeply into a patient's past, specifically at early life stressors. And this is a fraught topic. The research on adverse childhood experiences, or ACEs, shows a profound correlation with adult chronic pain.
It's a very sensitive area to navigate.
It is. We are talking about surviving physical trauma, emotional abuse, severe maternal stress during gestation, or even early medical traumas like premature birth requiring extensive time in a neonatal intensive care unit.
And the theory is that these extreme stressors occur while the nervous system and the immune system are in their most rapid, critical phases of development. The developmental timing is everything here.
So it changes how they grow.
Yes. Severe chronic stress in early childhood essentially trains the developing hypothalamic pituitary adrenal axis, the HPA axis, which is the body's central stress response system, and the central nervous system to become hypervigilant.
Through epigenetics, right?
Exactly. Through the mechanisms of epigenetics, early trauma can literally alter how genes are expressed in the nervous system. It teaches the developing brain that the external environment is fundamentally dangerous and unpredictable. As a survival mechanism, the brain sets the baseline sensitivity of its threat detection alarm system incredibly high.
I want to pause here and address a massive elephant in the room. If a doctor sits down with a patient who is doubled over in agony from a diseased, bleeding uterus and starts asking about their parents' divorce or emotional neglect they suffered at age 8, it can feel like a profound betrayal.
Absolutely can.
It feels perilously close to the historical victim blaming we just discussed. The patient hears, you have unresolved trauma, therefore your pain is your own fault for being too stressed. You need a therapist, not a surgeon. How does the medical community utilize this crucial risk factor data without alienating the patient and invalidating their intensely physical pain?
It requires immense clinical empathy and, more importantly, precise scientific education from the physician. A doctor must explicitly explain that the presence of an adverse childhood experience is not a psychological failing or an emotional weakness that the patient is somatizing into pelvic pain.
It's physical.
It is a biological structural vulnerability factor.
Yeah.
It is identical in concept to having a genetic predisposition to cardiovascular disease. If a patient inherits genes that cause high cholesterol and they subsequently suffer a heart attack, no logical physician would blame them for inventing the heart attack.
Right, you wouldn't say it's their fault.
Similarly, early life stress physically and chemically alters the structural development of the descending pain modulatory system. It changes the physical density of receptors in the brain. It is a measurable physiological reality.
So it's about hardware again.
By discussing ACEs, the physician is not blaming the patient. They are validating that the patient's nervous system was biologically altered by forces outside their control, making their current physical pain absolutely real, measurable, and highly complex.
It is the difference between psychological fault and biological vulnerability. That framing is incredibly empowering, I think. Beyond hormonal fluctuations and developmental trauma, we have to look at daily physiological factors. And the most critical one in the literature is sleep deprivation.
Oh, sleep is huge.
The relationship between sleep and pain modulation is absolute. There are foundational clinical studies, most notably the brilliant work of Harvey Moldovsky in the 1970s, that proved this beyond a shadow of a doubt.
His work was groundbreaking.
Moldovsky designed a fascinating experiment. He recruited perfectly healthy, pain-free, active college students and brought them into a controlled sleep laboratory. His goal wasn't to completely deprive them of sleep. He actually let them sleep through the night.
But he interfered with it.
Right. He continuously monitored their brainwaves using an EEG. Every time the EEG indicated that a student was transitioning into deep, restorative, slow-wave sleep, often referred to as stage 3 or stage 4 sleep, he used an auditory buzzer to subtly interrupt that specific sleep cycle, forcing them back into a lighter stage of sleep without fully waking them.
The methodology was brilliant because it isolated the specific biological function of deep sleep. These students were technically sleeping for 8 hours, but they were getting completely fragmented, non-restorative sleep.
And the physiological results were staggering. Within just a few days of being selectively deprived of deep, slow-wave sleep, these otherwise healthy athletic students developed widespread, severe muscle pain, profound fatigue, and measured hyperalgesia.
They temporarily developed the exact clinical presentation of fibromyalgia.
Simply depriving a healthy nervous system of deep sleep was enough to artificially manufacture nociplastic pain. Why is that specific phase of sleep so chemically vital?
Because deep, slow-wave sleep is the critical window when the central nervous system performs its essential maintenance. During this phase, the brain literally clears out metabolic waste products that accumulate during waking hours, including substance P, which is a key neurotransmitter involved in pain signaling.
Like taking out the trash.
Exactly. It is also the phase where the nervous system recalibrates the descending pain modulatory pathways. It essentially repairs the brake pedal. If you are chronically deprived of deep sleep, which is almost guaranteed if you are suffering from the intense nighttime pelvic cramping of adenomyosis, your nervous system is chemically incapable of repairing its pain inhibition systems.
So poor sleep and chronic pain form a vicious synergistic cycle that rapidly locks the central nervous system into an entrenched, sensitized state.
Precisely. So when a specialist is trying to solve the surgical dilemma, trying to determine if a patient's pain is bottom-up or top-down, they are analyzing this entire complex matrix.
They're looking for patterns.
They look for specific diagnostic clues. If a patient presents with adenomyosis, but they also have a deeply entrenched family history of chronic pain syndromes, if their pelvic pain initiated very early in adolescence, if they already suffer from multiple overlapping conditions like IBS and debilitating migraines, if their sleep architecture is completely shattered and they exhibit severe sensory hypersensitivity to light and sound.
That's a lot of red flags.
That entire clinical picture points heavily toward an entrenched, top-down nociplastic state. And in that scenario, rushing the patient into the operating room for a hysterectomy is a massive clinical risk. It may provide no relief, and the physical trauma of the surgery could theoretically escalate the central sensitization further.
Which brings us to the ultimate question, the gold standard treatment paradigm. Knowing all of these incredible intersecting complexities, the enmeshed canonical brain networks, the glutamate dominance, the profound difference between bottom-up and top-down pain, how do leading experts actually treat this pain effectively without inadvertently making it worse?
The consensus demands a highly coordinated, two-pronged approach. You must simultaneously remove the peripheral fuel and actively retrain the central brain networks.
Okay, let's examine the first prong, removing the fuel. This is where the clinical approach centers heavily on continuous hormone suppression, rather than immediately jumping to surgical excision. Why is hormone suppression the preferred initial strategy?
Hormone suppression is elegant because it allows the clinician to chemically extinguish the bottom-up peripheral fire without subjecting a highly sensitized nervous system to the massive physical trauma of major surgery.
So it's less aggressive on the body.
Much less. By utilizing medications that suppress the hormonal fluctuations of the menstrual cycle, such as continuous oral contraceptives, high-dose progestins, or GnRH agonists, the objective is to create a stable, low-hormone, non-cycling environment.
No cycle means no monthly proliferation of the trapped endometrial tissue, no breakdown, and, crucially, no bleeding inside the muscular wall of the uterus.
It chemically starves the adenomyosis. It physically shrinks the lesions and abruptly cuts off the massive cyclical release of inflammatory prostaglandins.
So the signal stops.
Yes. By halting that local inflammation, you stop the unrelenting bombardment of nociceptive danger signals traveling up the spinal cord. It is the equivalent of throwing a heavy, fire-retardant blanket over the localized fire. By stopping the relentless sensory input, you provide the hyperreactive, exhausted central nervous system a desperate, necessary window of quiet to begin naturally downregulating and recalibrating its threshold.
But simply quieting the uterus isn't enough because we have to address what the patient is likely taking just to survive their day-to-day existence. And this is perhaps the most difficult conversation a doctor has to have. A patient suffering from severe adenomyosis is frequently prescribed powerful opioid medications just to function.
Very frequently.
Yet the leading pain experts universally agree that the first crucial step in treating nociplastic pain is to completely remove the opiate.
It sounds harsh, I know.
To a patient in unending agony, taking away their strongest, most reliable painkiller sounds like absolute cruelty. Why is this agonizing step biologically mandatory?
It is arguably the most counterintuitive yet scientifically absolute principle in chronic pain management. Opioids are miraculous, necessary drugs for acute nociceptive tissue injury. If you shatter your femur in a car accident, or you undergo a radical hysterectomy, opioids are entirely appropriate and vital for managing that acute post-surgical pain phase.
But not for chronic pain.
Right. When deployed long-term against chronic nociplastic pain, opioids are biologically catastrophic.
Because they trigger a paradoxical reaction known as opioid-induced hyperalgesia. Let's really explain what happens at the receptor level when you introduce a synthetic opiate to a sensitized brain.
When you take prescription opioids daily, you flood the brain with external, highly potent painkillers. The brain's homeostatic sensors recognize this massive external flood, and in an attempt to balance the system, the brain completely shuts down its own internal production of endogenous opioids endorphins.
So the brain stops making its own painkillers.
Exactly. But it gets much worse. The continued presence of synthetic opioids actually activates glial cells in the central nervous system, triggering neuroinflammation. This neuroinflammation actively upregulates the excitatory glutamate pathways. Long-term opioid use literally trains the central nervous system to become structurally more sensitive and reactive to pain stimuli over time.
The opiate is physically rewiring the nervous system to turn the volume knob of pain up, not down. That is terrifying.
Yes. Furthermore, cerebrospinal fluid analysis reveals that many patients with nociplastic pain already possess highly elevated levels of their own endogenous opioids. The issue is that their neuroreceptors have downregulated and stopped responding to them. Introducing highly potent prescription opioids into that already saturated, dysfunctional environment is akin to pouring high-octane gasoline onto a grease fire. It rigidly locks the brain's neuroplasticity into a permanent state of hypervigilance.
So, maintaining a patient with nociplastic pain on strong opioid therapy is like a mechanic trying to fix a deep software glitch in your car's central computer by continuously swapping out the tires.
I love that.
Not only does it completely fail to address the underlying code error, but the constant aggressive tampering is going to end up stripping the lug nuts and breaking the axles in the process. You are causing profound structural damage to the system while entirely ignoring the actual problem.
That is a brilliant and accurate analogy. The physician must carefully, compassionately taper the patient off the opioids to allow their endogenous pain inhibition system the necessary space to boot back up. But ethically, you cannot simply strip away their coping mechanism and abandon them to the pain.
Right, you can't just leave them hanging.
As you taper the harmful medication, you must aggressively implement top-down treatments designed to retrain the brain's software.
What are the non-pharmacological interventions that actually alter this software? We talked about the enmeshed brain networks. How do we disentangle them?
The absolute foundation of top-down treatment is structured clinical education, a modality formerly known as explain pain.
Just explaining it helps.
Yes. Robust clinical trials demonstrate that when a patient is guided to deeply, scientifically understand the exact neurobiology we are discussing today, when they have that light bulb moment and realize their agonizing pain is an alarm system glitch, rather than an indication that their internal organs are actively decaying or tearing apart, their baseline neurological fear drastically decreases.
And fear is linked to pain.
Intimately. Because the neural circuits for fear and the neural circuits for pain profoundly overlap in the brain, reducing the cognitive fear physically reduces the intensity of the sensory pain signal.
So the knowledge itself acts as a neurological intervention? That's incredible.
It genuinely does. Building on that foundation, specialists utilize targeted psychological therapies. Cognitive behavioral therapy, CBT, helps patients identify and dismantle the catastrophizing thought loops that flood the brain with stress hormones.
And there's also PRT, right?
Yes. Pain reprocessing therapy is a newer, highly effective modality that specifically targets the brain's misinterpretations. It systematically exposes the patient to safe, mild physical sensations while employing cognitive techniques to train the brain to correctly label those sensations as safe rather than dangerous, slowly unmeshing the salience and sensorimotor networks.
But we also have to address the physical body, specifically sleep and the muscular response to chronic pain.
We extensively discussed Moldavsky's sleep research earlier. You absolutely must repair the patient's sleep architecture or the nervous system will never heal.
So how do you fix their sleep?
The clinical gold standard is CBTI, cognitive behavioral therapy for insomnia. It is scientifically proven to be far more effective for creating long-term restorative deep sleep than relying on sedative hypnotic sleep medications, which often prevent the patient from reaching that crucial slow wave phase anyway.
And what about physical therapy?
Physically, the patient requires highly specialized physical therapy. But this is not standard stretching or strength training. Pelvic floor physical therapy is absolutely vital.
Because the muscles are reacting to the pain.
Exactly. Years of agonizing pain signals cause the complex web of pelvic floor muscles to involuntarily clench, spasm, and guard. This constant muscle tension creates a secondary massive source of peripheral pain. A specialized pelvic PT uses biofeedback and manual release techniques to help the patient consciously downtrain and relax those hypertonic, exhausted muscles, further reducing the nociceptive input to the spinal cord.
Okay, so while the patient is doing this immense psychological and physical work, are there any pharmacological options that actually target the central software glitch? If opioids are actively harmful, what medications are appropriate?
Yes, there is a role for targeted pharmacology. Instead of prescribing medications that numb the peripheral pelvic tissue, specialists use centrally acting drugs that specifically target nerve hyperexcitability and central pain processing in the brain.
What kind of drugs?
These include specific classes of antidepressants, particularly SNRIs like duloxetine or milnacipran.
Wait, antidepressants for pain?
Yes, but the goal is not necessarily to treat clinical depression, though chronic pain is certainly depressing. The goal is to artificially boost the levels of noradrenaline and serotonin in the spinal cord, thereby chemically repairing the brain's broken descending pain modulatory brake pedal.
Oh, that makes sense. You're fixing the brakes.
Exactly.
Right.
We also utilize gabapentinoids, medications originally designed for seizures, like gabapentin or pregabalin.
Right.
These drugs specifically bind to calcium channels on the overactive nerves, effectively calming down the excessive release of excitatory neurotransmitters like glutamate.
Lifting the foot off the gas pedal.
Precisely. They're not magic bullets. They do not work for every patient, and the cognitive side effects require careful management. But structurally, they are aiming at the correct neurobiological target.
We have covered a tremendous amount of incredibly dense, paradigm-shifting science today. Let's pull all of this together to summarize for the listener. When you are dealing with a complex condition like adenomyosis, especially when the pain has become chronic, severe, and widespread, the pathology isn't isolated just in the pelvic tissue.
No, it's a systemic issue.
It is an incredibly complex, systemic, ongoing conversation between the reproductive organs and the entirety of the central nervous system. The adenomyosis might be the match that initially sparked the flame, but central sensitization is the raging forest fire that develops its own weather system.
That's a beautiful way to phrase it.
True empowerment for the patient comes from deeply understanding this precise neurobiology. It means you are not crazy, the agony is absolutely not a psychological invention, and there is a verified, scientifically mapped, structural reason why your entire body feels like it is burning.
And profoundly understanding the distinction between the physical burglar and the broken alarm system dictates every aspect of how a patient should pursue treatment.
It changes everything.
It explains why a holistic central nervous system-focused approach is vital, and why a patient might want to strongly pause and evaluate their nervous system's health before rushing into a radical, irreversible surgery that may completely fail to silence the internal alarm.
Which leaves us with one final, truly mind-bending concept to explore. We have established conclusively today that the brain possesses the neuroplasticity to physically rewire itself and meshing the default mode and salience networks, altering its receptor density, shifting its chemical balance to essentially learn how to be in a state of chronic, inescapable pain.
The brain learns the code of pain.
But neuroplasticity is a two-way street, isn't it? If our central nervous systems are powerful enough to construct these entrenched pain pathways entirely independent of ongoing peripheral tissue damage, could the future of treating horrific chronic diseases like adenomyosis rely significantly less on surgical scalpels and traditional pharmaceuticals?
It's very possible.
Could we be looking at a medical frontier entirely reliant on advanced technologies such as precisely targeted transcranial magnetic neuromodulation, or carefully guided, clinically administered psychedelics that promote rapid synaptogenesis that allow us to consciously, deliberately unlearn pain by deleting the maladaptive software code that causes it?
That concept is the absolute frontier of pain science right now. The profound hope of neuroplasticity is that it is fundamentally reversible. If the brain can physically wire the pain in, the brain possesses the latent capacity to wire it back out.
It's an incredibly hopeful reality buried within a terrifying diagnosis. So, to all you out there navigating this complex landscape, the next time that internal alarm system goes off, remember the science. You might have already kicked the burglar out of the house, or you might be working on chemically starving them out right now. Regardless, the true healing comes when you understand the hardware and begin the profound work of learning how to rewrite the code.